Welcome back, everybody. Our topic here is multiple gestation, and we are primarily going to stick to twins. However, multiple gestation includes triplets, quadruplets, and higher order pregnancies as well. So keep that in mind, but we're going to focus on twins because that's what's most likely to come up on a licensing examination, and it's also the most common multiple gestation. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of the video. If you could consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I go over case studies and forming differential diagnosis, treatment plan, etc. And that should be of great use to you as you get ready to study for Step 3 of the USMLE with the clinical case scenarios, as well as for impressing your attendings on rounds. So we're going to first start out with a brief overview of multiple gestation. We'll talk about the embryogenesis of how this actually happens. It can be very simple or very complex depending on what kind of twinning you actually have. We'll talk about the different types of twinning, dizygotic twinning being the most common, and then monozygotic twinning, in which we have to distinguish whether or not there's a shared chorion and whether or not there's a shared amnion or amniotic sac. We'll talk about the diagnosis. This is really a sonographic diagnosis, so we want to be able to point out the sonographic features which will help you determine either the zygosity or the chorionicity and amnionicity. And then we'll talk about the management. That is very, very important because the way we manage mothers of multiples is going to differ a little bit from the way we manage mothers of singleton pregnancies, and the reason is that there are more complications, higher risk of complications, and we need to get out in front of that. So, twins naturally occur in approximately 1 in 80 pregnancies in the U.S. Note, I say naturally occur. So, the actual rate is higher than that because there are a number of couples that do assisted reproduction, namely in vitro fertilization. And that's going to raise the risk of having multiples, particularly higher order multiples like triplets and quadruplets. However, the majority of twins are actually not related to assisted reproduction. The majority of twins are actually they actually occur naturally. Additionally, 96% of multiple gestations are twins. So when we say multiple gestations, we're primarily talking about twins. However, 4% of the multiple gestations are actually higher order, triplets, quadruplets, and so forth. Now, when we're talking about those higher order gestations, triplets and quadruplets, 77% of those occur from infertility treatment. So that's, like I said, infertility treatment is things like in vitro fertilization. It's also things like clomid, clomiphene, which induces ovulation. Certainly that will raise your risk of multiple ovulations. So of twins, 70% are dizygotic, meaning 2 eggs fertilized, and 30% are monozygotic, meaning 1 egg is fertilized and then there is a subsequent split. Multiple gestation is associated with higher rates of almost every potential complication of pregnancy, with the exception of post-term delivery and macrosomia. So there's a higher rate of preeclampsia, much higher rate of preeclampsia, higher rate of gestational hypertension, higher rates of gestational diabetes, higher rate of preterm delivery, and so forth. Okay, so these are high-risk pregnancies, and so they need to be managed much more closely and be followed much more closely. Very important. Symptoms of a multiple gestation. Now, usually we don't rely on symptoms. The way it typically goes is a woman has a positive pregnancy test, and then she comes in to get a confirmatory ultrasound. We do the ultrasound, we see 2 sacs, 2 gestational sacs, and we know then that it's twins. Okay? So The symptoms really are more prospective, what we expect to see with somebody that we already know has twins, because usually we're going to pick it up on ultrasound before we actually see the symptoms. So these symptoms can include an increased incidence of hyperemesis gravidarum, morning sickness, and larger than expected fundal height. And that makes sense because there are multiple gestations within the woman. If you were to get a quantitative HCG or an alpha-fetoprotein, those levels will be higher relative to the date. So if for some reason you did not do an ultrasound and you were to get these levels, then you would see that it's higher. But like I said, in the majority of instances, the woman is going to come in for a confirmatory ultrasound, and at that point you're going to diagnose the twins. You don't have to wait for these symptoms to show up. Risk factors for twinning. So as I said, assisted reproduction, clomiphene, also known as Clomid, human menopausal gonadotropin, also known as Pergonale. These things are big risk factors. We see in a lot of these assisted reproduction, in vitro fertilization, there are multiples. In many instances, with in vitro fertilization, it's because multiple embryos were implanted with the expectation that some may not take. And in some instances, maybe they all take, and now you have quadruplets or triplets. Or in some instances, none of them take, and it's failed. So that's why multiple embryos are placed, but if they all take, then you can have easily have a multiple gestation. With clomiphene, what you're doing is you're inducing ovulation. And usually multiple eggs will be released. In many instances, multiple eggs will be released, and so obviously that's going to raise your risk of multiple gestation. For some reason, there's an increased risk of twinning in African Americans. Not sure why that is. Increase in women who have had previous babies. When there is a family history, not so much in the father, but in the father's mother, there may be some link to that, but definitely in the mother. Okay, so the mother's family history or the father's mother's family history, the paternal grandmother. There is a slightly increased risk if the woman is obese, if she's tall, and that height is really not really that tall, 5'5", but the taller she gets, the higher the risk of twinning. And then geography. So it even goes beyond race. What we actually know is that in a region of southwest Nigeria, there's a 1 in 20 incidence of twinning. That's really high. But if you compare that to the rest of Africa, it's not quite that high. Okay, so it goes beyond race, and geography plays a role as well. Now, I don't think that if you have a white couple that moves to southwest Nigeria, I don't think their odds are going to go up from 1 in 80 to 1 in 20. But it does go beyond just race, and it does apply to geography, where the person's ancestors come from. So the fetal complications of multiple gestation obviously include prematurity, and if a baby is born premature, there's an increased risk of cerebral palsy and mental retardation, abnormal and or discordant growth. So if one twin receives more blood flow than the other, we call that twin-twin transfusion syndrome. You can have discordant growth in which one baby grows more than the other. That is something that we want to look for when we're doing serial ultrasounds towards the second and third trimester. Congenital anomalies, there's a slightly increased risk of congenital anomalies when there's twins, and then the death of one twin. That can be a big problem. Maternal complications include, as we mentioned, hyperemesis gravidarum, iron deficiency anemia, simply because of the increased demands. I would also say that there is an increased risk of macrocytic anemia as well. Increased risk of preeclampsia, eclampsia, increased risk of intrahepatic cholestasis, and then an increased risk of thrombosis, and very important, postpartum, increased risk of hemorrhage due to uterine atony, and that's because of the enlarged uterus. The uterus is much more distended than in a singleton pregnancy. So this is a bit of a flashback to embryology, which for most medical students is one of their most hated courses, and the reason, I think, is because it's so complex, and this diagram is no exception to that rule by any means. I don't want you to memorize this for step 2 and 3. Step 1 is a different animal, but for step 2 and 3, you don't need to memorize this. What I want you to remember, though, are a couple different points, a couple different landmarks where some very important things happen. So at day 1, you have fertilization of the ovum, and that occurs in the fallopian tube, but it takes about a week for that fertilized ovum, that embryo, to make its way down to the uterus, ideally, where it will then implant. But during that week, you have a lot of activity going on. So for the first few days, you have cellular division. That cellular division will ultimately yield this 16-cell mass, this compact mass, which we know is the morula at day 3. At day 4, then, you start to have differentiation of that morula, where the outer cells will form what we know as the trophoblast, and the inner cells form this inner cell mass. And so by day 5, you have this hollowed out mass here, where the outer cells are the trophoblast and the inner cells are the inner cell mass. The trophoblast is going to form the chorion, and for our purposes, chorion equals placenta. They're not exactly the same, but when you hear chorion, think placenta. So trophoblast will form the chorion or the placenta. The inner cell mass will form eventually what will become the fetus itself. So by day 7, you have implantation, and then shortly after implantation, you have further differentiation of the inner cell mass. And these cells will eventually form the amniotic sac and the yolk sac, and together in between there you have what will become the fetus. So at day 9, another important point, you have the beginning of the formation of the amniotic sac. So 2 important points here. Day 4, the beginning of the formation of the trophoblast or placenta. Day 9, the beginning of the formation of the amniotic sac. Day 4 and day 9. Okay, so why is this important? If the splitting occurs before the trophoblast begins to form, you are going to have 2 embryos with separate trophoblasts. So if your splitting occurred at day 2, for instance, you're going to have 2 embryos with their own trophoblastic layers. That means you're going to have 2 separate placentas. And because the amniotic sac hasn't even begun to develop yet, you're going to have 2 separate amniotic sacs. And so what we are left with are separate placentas and separate amniotic sacs. So we call this dichorionic, diamniotic. 2 chorions, 2 amnions. If the splitting occurs after the trophoblast has formed, but before the amniotic sac has begun to form, so between day 4 and day 8 roughly, then you are going to have 1 chorion because the trophoblast is already formed, but you're going to have separate amniotic sacs because the amniotic sac has not begun to form yet. So while you have these 2 separate inner cell masses, you only have 1 trophoblastic layer. So you have 1 placenta, but 2 amniotic sacs. So we call that monochorionic, 1 chorion, and 2 amniotic sacs. So this is monochorionic, diamniotic. If the division, if this separation occurs after the amniotic sac has begun to form, now although you're going to have 2 embryos, 2 fetuses, you're only going to have 1 amniotic sac, and of course you're only going to have 1 placenta, 1 chorion. And so we call that monochorionic, monoamniotic, 1 placenta, 1 amniotic sac. Okay, so it depends on when the division occurs. If the division occurs before the trophoblast layer forms, you're going to have separate placentas and of course separate yolk sacs. And if it occurs after the yolk sac, after the amniotic sac has begun to form, then you're only going to have 1 amniotic sac, and of course you're going to have 1 placenta because that trophoblast layer has long already formed. So we talked about our 3 different types of monozygotic twinning. Remember, monozygotic is identical twinning, if I haven't mentioned that already. And it all depends on when the separation of the embryo into 2 unique embryos occurs. So with dichorionic, diamniotic, it's very early. This is also known as di-di twinning. Occurs in 25% of cases, and this is where you have separation up to and including the morula stage, before that trophoblastic layer has differentiated itself. If you have separation before that point, both unique embryos are going to form their own trophoblastic layers, and that's going to result in separate chorea, separate placenta. Of course, because the amniotic sac doesn't begin to form until around day 8, you're going to have also separate amniotic sacs. On sonography, we'll see a membrane between the two twins, as well as this little peak. And this is called the Lambda sign. We're going to go over sonographic features in a few minutes. If you have separation after the trophoblastic layer has begun to form, but before the amniotic sac has begun to form, then you will have a shared placenta, but you'll have separate amniotic sacs. This is called monochorionic diamniotic, also known as Mo-di twinning, and this is the most common type of monozygotic twinning. So in this case, you'll see a membrane between the two of the twins, but it'll be a slightly thinner membrane for reasons we'll go into in a little bit. The major complication here is twin-to-twin transfusion syndrome. And twin-to-twin transfusion syndrome can happen anytime where you have a shared placenta. And basically what's going on here is you have an issue with the vascularity of the placenta, and it's causing more blood to go over to one twin than to the other. And so one twin is going to be deprived of blood and is going to grow really slowly, while the other twin is going to grow really rapidly and it's going to be much bigger. And I'll show you a picture of that on the next slide. And then of course we have monochorionic monoamniotic, and this is where you have separation after the amniotic sac has begun to develop, so 9 to 12 days. And our major complication here includes twin-to-twin transfusion syndrome because you have a single placenta, and umbilical cord entanglement. Now, why do you not see umbilical cord entanglement in these other types of twinning, only in Mo-Mo twins? Because in order for the umbilical cord to entangle, the two umbilical cords to entangle with one another, they have to be able to contact one another. And anytime you have two separate amniotic sacs, remember there's a membrane between those amniotic sacs. Each amniotic sac has a membrane. And so that's going to prevent those umbilical cords from coming in contact with one another. But if you have a single amniotic sac, there's nothing in between the umbilical cords, and so they can entangle. So this is an example of twin-to-twin transfusion syndrome. So what's our chorionicity and amnionicity in this diagram here? So you see that we have a single placenta. Do we have separate or shared amniotic sacs? Wow, this is separate amniotic sacs. You can see this separate amniotic sacs here. So note here that you can't really see it in the diagram, but one twin is getting more blood than the other. And so this one twin here is getting really big and growing, has lots of blood, more blood really than it can handle, and it's going to be peeing out a lot because it's getting so much blood. Compared to the other twin, where it's getting very little blood, not going to be peeing out much at all, and so you have oligohydramnios and anemia in this twin here. This is the donor twin who's giving up the blood, who's not getting enough blood, and this is the recipient twin. And the recipient twin is bigger. So you can see here, this twin here is the recipient twin, much bigger, and this is the donor twin, much, much smaller. It's actually the recipient twin that's probably going to have more problems after delivery, because it's been getting so much blood, more blood than its little heart can handle, and so you have some congestive heart failure from that. Okay, so it's usually the donor twin that fares a little bit better. This is umbilical cord entanglement. Remember, only in Mo-Mo twins, where you have a shared amniotic sac. And you can see that these can become very, very, very entangled. So this is a twin pregnancy. This sono was taken at about 9 weeks gestation, and it's about 10 to 14 weeks gestation where we can really see these sacs, and where we can really see particularly the membrane. Now you can see the separate sacs really early on, and often, 5-6 weeks gestation, you can diagnose twins because you see two separate sacs. However, it takes a while to be able to see this membrane. And the membrane will help you determine the chorionicity. So we know that there are two separate sacs here. So we know that this is a diamniotic twinning. But is this a shared placenta, or are these separate placentas? It's hard to tell. more than likely we have separate placentas here. This is more than likely dichorionic diamniotic. For reasons that we're going to talk about, we're going to see these signs, but this looks like what we're going to see as the lambda sign. So in order to understand why you have this lambda sign and this peak here, it's important to understand what forms this intertwin membrane. So this membrane between the two sacs. So when you have dichorionicity, when you have two separate chorions, within this membrane that separates these twins, you're going to have intervening chorion. And so it's going to be thicker than if you weren't to have intervening chorion. So with dichorionic twins, you have intervening chorion between the membranes. On the other hand, when you have monochorionic twins, you have a very thin layer because you don't have any chorion between the amniotic sacs. And so it's going to be a thinner layer. And so this is what you would see in monochorionic diamniotic. Now, if you have monochorionic monoamniotic, you're not going to see any kind of membrane at all because you have only one sac. That membrane is the separation between the two sacs. Okay, so I probably shouldn't have included it here, but you certainly are not going to see a membrane in a monochorionic monoamniotic twin. So these are two important signs that you'll want to know. It may come up on the test, but certainly if you're doing sonographies on pregnant women, this will be very important. So this is called the lambda sign. It gets its name from the Greek letter lambda, the shape of the Greek letter lambda. And so you see that you have an intertwin membrane here, but then you have this sort of triangular peak. And this is actually a peak that's happening between the two separate placentas. Now the placentas look like it's just one placenta, but they're right up next to each other and kind of fused. So while it's two separate placentas and two separate circulations, it's hard to tell without seeing this peak here. And the peak is what tells you that you have two separate placentas. So you have this peak and then this intertwin membrane, which together make what looks like the Greek letter lambda. Now on the other hand, when you have a shared placenta but two separate amniotic sacs, you'll have an intertwin membrane, which we see here. It's much thinner, but you can't really go on the thickness or thinness of the membrane. But you're not going to have that peak. You're not going to have that twin peak that you see with the dichorionic. So here you just have an intertwin membrane. We call this the T sign. Okay, so you see here you have two separate amniotic sacs and the twin membrane, but no peak. So no lambda sign, but you do see a T sign. This is your T sign right here. So here is a lambda sign. You see a nice thick intertwin membrane and this twin peak here. So lambda sign. This one's a little bit less obvious, but you see your intertwin membrane here and then your twin peak right here. So dichorionic diamniotic twins. And this is what the placenta looks like, and you see that you have intervening chorion between the two placenta, but the two placenta are right next to each other. So if you didn't look for that twin peak, it would be very difficult to tell what kind of chorionicity you have because the placenta are right up next to each other, and a lot of times they're kind of connected to each other. But they notice that they have their own circulation. There's no intervening circulation between the two placenta. Same thing here. So this is the T sign. Okay. So T sign right here. So if you look back here, here is your T sign here. And here is your T sign here. So you have your intertwin membrane and then the placenta. So we know that we have two separate amniotic sacs because we have an intertwin membrane, but we don't see the twin peak, and so this is probably a shared placenta. Now, as I said, 10 to 14 weeks is the best time to be able to tell, because as these amniotic sacs get bigger, the size of this this inner twin membrane is actually going to get thinner because it's going to become more compressed, and eventually you're going to have crowding, so it's going to be hard to tell, and the inner twin membrane will actually start to kind of disappear. And so if you don't look for this until it's too late, you may accidentally diagnose this as Momo twins because you can't see the separate amniotic sacs. Again, here you see the T sign. No twin peak. That's what's going to set you off. So you see the membrane, but no twin peak. So these are the Modi twins. Monochorionic, diamniotic. So what is this? I'm asking you here. You can pause it if you want, zoom in. What kind of twinning is this? So first question, is there an inner twin membrane? You see your two fetuses here. Is there an inner twin membrane? If the answer is yes, you know it's diamniotic. Is there a twin peak? If the answer is yes, then it's dichorionic. If the answer is no, then it's monochorionic. And the answer here is no. No twin peak. So you have your T sign, so this is monochorionic, diamniotic. So it's shared placenta. What about this one here? So it's hard to tell here. You can see as they start to get bigger, it can get harder to tell. But what about right here? So is there an inner twin membrane? Yes. Is there a twin peak? Do we have our lambda sign? Right here. You see two of them actually. So these are di twins. Now what about this one? What do we have here? Do we see a membrane? No, no membrane here. So there's no membrane. So we know because there's no membrane that they must be monoamniotic, and you can't have dichorionic monoamniotic. It doesn't exist. So these are Momo twins. Monochorionic, monoamniotic. Big complication from here, umbilical cord entanglement. So our management for women who we've diagnosed as carrying multiples, we want to make sure that they're getting their vitamins and minerals. One of the big complications that can come out during the pregnancy is anemia, and that can be iron deficiency anemia or folate deficiency anemia, which would be macrocytic. So we want to make sure they're taking 1 gram of folate, 30 milligrams of iron every day. We want to make sure that all pregnant women are getting nutritional supplementation, but it becomes all the more important when they're carrying multiples. Ideal weight gain is going to be a little bit higher than for singleton pregnancies, 25 to 54 pounds for twin pregnancies. Now, if they already have some meat on their bones, if they're overweight or obese, then it's probably going to be closer to 25 pounds. If they're really thin women, probably going to be closer to 54 pounds. At 10 to 14 weeks, we want to get a sono to determine the chorionicity and amnionicity, and that's important because if these are Momo twins, we need to keep a much closer eye on them than if they're di twins. 18 to 22 weeks, we get our fetal anatomic survey, and then this is where there's some disagreement. How often do you get serial ultrasounds during the second and third trimester? Certainly you're going to get them more than a singleton pregnancy, but how often do we get them? Really just depends. There's disagreement, but you're going to get it more frequently if you have Momo twins than if you have di twins. At 28 weeks for Momo twins, we give antenatal steroids always at 28 weeks because the risk of delivering imminently is so high. We want to make sure that we've got antenatal steroids on board so that their lungs are developed before they are delivered. Induction of delivery should be done at 34 to 37 weeks for monochorionic twins, possibly towards the earlier end of that or even earlier than 34 weeks for Momo twins, and probably more towards 37 for Modi twins. 38 weeks for di twins. So these are elective inductions. At any point where you have significant fetal growth restriction, this is why you're getting serial ultrasounds, you want to deliver because of the possibility of twin-twin transfusion syndrome. And then you'll assess the fetal lung maturity anytime you're going to be inducing delivery before 38 weeks. And if there is inadequate fetal lung maturity, give steroids before delivering. Intrapartum, one of the common questions that comes up is whether or not you can do a vaginal delivery. For the purposes of testing, You can only do vaginal delivery if both twins are in cephalic presentation, which happens almost half the time. Now, there's disagreement on whether you can deliver the twins if vaginally if the first twin is in cephalic presentation but the second twin is not. There's disagreement. We're leaning towards trying to do more vaginal deliveries, so in many cases it will be yes, but the test will not ask you that because there's disagreement. Now, never will you do a vaginal delivery if the presenting twin is not in cephalic presentation. In that case, you will always go on to C-sections. You'll also always do C-sections if you have monoamniotic twins. And the reason is because when the first twin is delivered, there's a strong possibility that the cord of the second twin will come down and you'll have an umbilical cord prolapse. And that is a huge obstetric emergency. So we just do cesarean sections for all monoamniotic twins. For some reason, the second twin seems to have more complications. So the first twin being the first twin that's delivered, the second twin tends to have more complications, more morbidity and mortality. There tends to be a lower birth weight. There is a higher risk of malpresentation, higher risk of cord prolapse, as we already said, and a higher risk of that twin's placenta abrupting. So after delivery of the first twin, very important, once that first twin is out, that you clamp the umbilical cord as quickly as possible, certainly before you cut it, because all that blood, if it comes out, is going to be coming away. It's going to basically act like a drain on the second twin. So very important that you clamp the umbilical cord as quickly as possible to avoid exsanguination of the undelivered twin through the unclamped cord. That's an easy way to kill the second twin if you don't do that. Postpartum, the major complication, uterine atony. Why? Because the uterus is just more distended than it would be in a singleton pregnancy, so the risk of uterine atony goes up. So you want to make sure that these women are getting oxytocin after delivery, and you want to keep an eye on or a hand on their uterus to make sure it gets nice and firm and not soft and boggy. There is possibly an increased risk of postpartum depression in mothers of multiples. Not sure why that is. Possibly because you have multiple placentas, maybe hormonal, or it may be that twins are just more work, and so there's socioeconomic factors behind the depression. We don't really know. We just know that there's possibly an increased risk. So to recap, twins occur in 1 in 80 natural conceptions. Overall incidence is increasing due to artificial reproductive technology and fertility medications. And certainly the incidence of large multiples, 3, 4, 5, is also increasing as well. Diagnosis, sonography. Woman comes in, she wants to know if she's pregnant, you do a sonogram, you're going to see 2 amniotic sacs. You should only see 1 amniotic sac. You see 2 amniotic sacs, it's probably twins. It certainly is twins. Monochorionic diamniotic is the most common type of twinning. In that case, you have a shared placenta and 2 amniotic sacs, 2 separate amniotic sacs. And the major complication from that is twin-to-twin transfusion syndrome, of course, along with all the other complications of twinning. Major maternal complications are hyperemesis gravidarum, and that's just because the HCG level is higher, and that's the cause of the hyperemesis gravidarum. And also, she has a much higher risk of preeclampsia because there's just more placenta. And it's the placenta that we think is the originating etiology of preeclampsia. Major fetal complications are prematurity, that goes for all twins, and twin-to-twin transfusion syndrome in monochorionic twins. There's a higher risk, though, of virtually all pregnancy complications when you have twins, and that goes for monozygotic or dizygotic twins. Very important to determine the chorionicity, amnionicity in the second trimester, or I should say here, before the second trimester, so 10 to 14 weeks. Twin pregnancies need to be monitored more intensively. Dichorionic twins should be induced at 38 weeks. Monochorionic twins are induced earlier. Steroids and induction should be done if there are signs of fetal growth restriction, and uterine atony is the major postpartum complication for mom. And I should point out an obvious sign, but if you're doing the ultrasound and you note that the twins are different genders, you know they're dizygotic twins. Okay, I just thought I'd point that out, but that may come up on the test. You see a boy and a girl. What kind of twins are this? you know it, because you can't have identical twins of opposite genders. So this is something interesting, and this won't come up on the test, but this is something interesting. This mom delivered twins. But look at them. One is way darker than the other. One's got brown skin, brown eyes. The other's got pale skin and blue eyes. This is something that can happen. It's actually not terribly uncommon. It's called heteroplacental superfecundation. Heteroplacental superfecundation. What happened here was she ovulated, got pregnant, and then she just happened to ovulate again and got pregnant again. And so what happened, she probably got pregnant by a darker skinned male the first time and by a fairer skinned male the second time. And this has to happen within a few days of one another. This is very common in other mammals, not very common in humans, but you have twins, but they have separate fathers. Here you see another instance here. Heteropaternal superfecundation. I saw a movie about this. Of course, it was like one of those Lifetime made-for-women movies. It's all dramatic. And the girl got pregnant. She got raped by one guy and had a consensual sex with another, and then found out she had... women. They seem to like that stuff as entertainment. Interesting. And here you see 100-year-old identical twins. Both survived. Longevity, probably a lot of genetic factors. That's all I have for you. If you have any questions, please write me a note below. Otherwise, I will see you next time.